Congratulations to both of you, and thank you for everything you've done. It is my pleasure now to introduce our keynote speaker for the night. Dr. Jim Sabin knows medicine, he knows psychiatry, and he knows families. He's an educator and a researcher. He's a doctor who directs public policy, and he's created a nationally recognized ethics program. Dr. Sabin is a clinical professor of psychiatry and of ambulatory or preventive care, which we can also call internal medicine. Yes, doctor? Yes. He is also in charge of the ethics program at Harvard Pilgrim Healthcare. He is at Harvard Medical School, and we're very, very happy to have him with us tonight. He's a wonderful speaker, Dr. Jim Sabin.
So I feel as if I'm going to heaven being here. From medical school on, I thought that families and the community were a crucial part of healing from major ailments, mental illness and others, and we've really seen that in action here tonight, and in a very impressive way. I want to pick up on something that Ken Barlow said, which I've harried students about. If you listen to him, he said recurrently, I have bipolar illness. He didn't say I am bipolar. And there's no such thing as a type of person. There are people who have bipolar illness, schizophrenia, alcoholism. And I like to say to my patients with bipolar illness, because trying to understand what's going on with me is a central part, that you're a normal, healthy person who has something. So thanks for using that verb. And the other Ken talked about resilience, which is a big, big deal. And what Ken Lampert said is that some of us are blessed with resilience as part of our psyche, but it's something that can be developed. And in developing it, along with the practices he talked about, family. Ken's mother is here, Danielle. Family and community are crucially important. Okay, so these are the themes I want to discuss tonight. The first is that we in the U.S., it's both a blessing and a curse about us as a people. We have great respect for the individual, and a lot of you are from New Hampshire. Live free or die. So we have great respect for the individual. All around the world, people admire that. But there's a downside to our individualism, and that is that we tend in many ways to treat individuals as individual atoms of rights, isolated individuals. That has a lot of bearing on dealing with mental ailments. These are culturally variable attitudes. I'll say a couple of things about that. Those of you who are in the health field, and those of you who have dealt with health professionals around family members with major ailments may have encountered a major law, HIPAA, and it has been used in ways that really cause a lot of problems. And finally, I make a couple of suggestions. So when I was thinking about what to say, Bob Dylan's song popped into mind. If this were a smaller gathering, I'd sing it for you, but I won't afflict you with that. But in terms of individual atoms, look at the lyrics. My wife Marjorie and I can remember, a lot of you are not old enough, at least you know who Bob Dylan is, but you wouldn't remember when this song came out. And we heard it on the radio in Los Angeles, and we thought, wow, this is really something. But look at those middle lyrics, sung in Dylan's great way, about how your mothers and fathers, your sons and your daughters are beyond your command. Your old road is rapidly changing. Get out of the way. And that was in 1964 when that song was released. But in a way, it's part of our culture. Families, get out of the way. In the mental health field, when I was in training, doing my residency in Boston, there were concepts that both drove this view of families as the enemy of the individual, and that we're fed by our cultural view that the individual was the locus of rights and others were fighting against it. There was a phrase, that happily has gone out of existence, but the schizophrenic mother. It was believed that schizophrenia was caused by what the mother did. Imagine what that meant, and imagine how this played out in a hospital if a person was there with an acute psychosis and the family is visiting, and the theory in the background of the mind for the professionals is they did it. The schizophrenic mother, the refrigerator mother, the mother who's so like the ice compartment of the refrigerator. And two theories, which I won't go into in detail, but the fourth one, Bruno Bettelheim, who wrote a book in 1967 about autism. It was a very well-written, engrossing book, but it had a hypothesis that was both false and profoundly harmful. The hypothesis was that the cause of autism was the parent, particularly the mother's wish that the child would be dead. You're right to gasp. This is kind of the background climate. These specific ideas aren't with us anymore, but that's the cultural milieu in which families and the health professionals and the whole group is interacting. If you think about our commitment laws, which vary from state to state, but the laws under which someone who is acutely unwell can be committed to a hospital, we're very protective of the individual. And that has a lot that's very good in it, because in other countries, this was very clear in the Soviet Union. Involuntary hospitalization was used as a form of political oppression. And if you had a deviant political opinion, you'd be clapped into the hospital as an insane person. Here, perhaps the IRS might harass you a little bit, but you're not hospitalizable for a far-out political opinion. The criteria for containment, which are significant criteria, but if you think of them, they're very, very limited. The typical one is imminently dangerous to oneself or to others. These leave out people who are profoundly unwell, but who aren't dangerous to themselves or others. And over the years, I had conversations with a number of family members. It was very poignant. I remember the sister of one of my patients. The person with the ailment had been a teacher, a really terrific teacher. And I saw her annual reviews. Either she or the sister gave them to me. Wonderful, 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 a little bit disorganized, profoundly out of it, as schizophrenia set in. And the sister said, "Why can't you do anything?" And I had to explain because the person with the ailment wouldn't take medication, as is unfortunately not uncommon, didn't think anything was wrong with her, and was clearly deteriorating. I had to explain that we in the US tilt strongly against the possibility that people will be oppressed and deprived of their liberty. And the downside of that is that people like your sister can deteriorate without what might be potentially helpful to them. Here's where I was going to talk about cultural variation. When in 1986, we were in China with a group of psychiatrists and professors visiting with folks in the same fields. And when colleagues of mine and I met with psychiatrists in Shanghai, we asked them, how do you handle the situation for someone who has an ailment like schizophrenia, who does well on medication, but who won't take the medication? And they didn't understand our question. They thought we were just infinitely stupid. They said, well, if Chang-Mi needs medication to be well, we would say to the village leader, Chang-Mi needs his injection every 2 weeks or every 4 weeks, and he would get it. And we realized, first, how different cultures are, but there are advantages to an authoritarian system. There are major disadvantages to authoritarian systems. But for someone with an ailment of the sort we were imagining, this was a supportive environment. I don't know whether we would say the ailment was stigmatized, but it was approached very realistically. Here's our village member who needs something, the way someone might need food or water or to have their house repaired, getting help with it, and they would do it. Another example, in India, I spent a day with a psychiatrist in a clinic serving rural people. Now, we think doctors here are busy. He saw 60 units, I wouldn't say patients, because no one came alone. One person out of 60 in the day came alone. Everyone came with 2, 4, 6, 8, 10 relatives. And they would gather in front of the desk and interact with the psychiatrist. So the milieu within which ailments materialized, and Ken Barlow talked about his wife. I don't know how old your children are, but whether they pitch in. But family members, I love the story about his wife recognizing his footsteps if he's walking a little bit heavier or faster. And you can picture her saying that to him or calling the physician and saying he's tromping a little bit on the floor. And everyone would know what that meant. And that's the way things should work. And it calls for a kind of fluid interaction between the self-managing individual, the people who are close to him or her, and the health professionals. The third example that taught us about culture, we were at a hospital in Varanasi or Benares in India, being shown around by a resident, a psychiatry resident who'd grown up in the States, so he seemed like a real Yank. He had an American accent, American manner, but his family had come back to India. He was doing his training there. And we knew that if you came to that hospital, family members came with you. You didn't come alone. They would come and be part of the whole treatment. And we asked him a very American question. Weren't people concerned about their privacy? It's a very American question. And the striking thing was he didn't understand us. What he responded to was what they're concerned about is being excluded from the family. And the family being there was crucial for them. So our very American culture-driven, privacy-focused, individual atom way of thinking just didn't make sense to him. Now, just to give me a sense of it, how many have heard of this law called HIPAA? Oh, it's almost everyone. This is a very learned group. Has the hockey team heard of it? You must have made a lot of saves, Colin, to raise all that money. So this law, the Health Insurance Portability and Accessibility Act, Accountability Act, has a lot of noble purposes. But it's actually, how many of you have encountered problems dealing either as clinicians dealing with families or as family members dealing with, well, it's quite a fair number. So you know what I'm talking about. This law is often experienced by health professionals and encountered by family members and close friends, like Ken talked about Lisa and Philip, as a barrier, like an iron curtain. I can't talk to you because of HIPAA. HIPAA prevents it. Here's one quote from the law, and it has some very interesting and important features. I teach medical ethics, and when I taught psychiatry, interpreting these terms would be important. So I underlined the important terms. So what does this say? If the individual is not present, or the opportunity to agree to object to disclosure can't practically be provided because of the individual's incapacity. So one question is, what constitutes an incapacity? If someone's unconscious, that's obviously an incapacity. But any of us who dealt with ailments that affect the way we think and feel in a major way know that incapacity, you can look well, you can talk coherently, and incapacity can be present. So there's the term incapacity. And then in these circumstances, clinicians may, in the exercise of professional judgment, determine whether the disclosure, interaction with the family or friends, is in the best interest of the individual. For those of you who are interested in this, on April 26th, there was a hearing of the House Commerce Committee. This is in the aftermath of Newtown and Aurora, with a focus on guns and violence, but it has much broader implications. There was a hearing on this law, and the director of the Department of Civil Rights in HHS, in the government, was very clear that the law is intended and it's enforced with respect for professional judgment. It's not intended to replace that. And what the privacy intrusions that it's concerned about are not nurses and doctors talking with families. It's leaving your laptop on the tee with all sorts of personal information that's not encrypted, or not having security systems on your automated medical record. That's what it's concerned with. It's not concerned with that dialogue around around the needs of an individual between health professionals and family members. It's actually quite sociologically interesting what's happening here. Why has it turned into this monstrous barrier? Well, one reason is that health professionals, especially physicians, have PTSD over being sued. Being sued is a big deal. It really is a trauma. All of the malpractice companies have mental health professions working with them to help people being sued and being accused of being monstrously harmful, dealing with that trauma. So health professionals are very afraid of being sued, even though this law creates no right to sue. That's a background concern that comes from outside of the unit of the patient and the family and the concerned others. And in the training that happens, are there any lawyers here? I don't want to insult lawyers. If you are, I apologize. But the training in many hospitals is carried out by the risk management staff and the legal staff. And their job is, how do we stay out of trouble? And so they basically convey the message often, keep your mouth shut. Err on the side of reticence, on the side of quiet and the side of non-interaction. So that's a message that people can get. And then there's the simple but serious fact that many of us are not well trained in dealing with families. There are specific skills medical students and nursing students are taught about doing a clinical interview and relating to patients. not as many are taught about how do you deal with families, how do you deal with Philip and Lisa, how do you incorporate others into the care process in a way that is attuned to the individual's sense of privacy. I mean, Ken spoke to this, Ken B, so well, attuned to the individual's sense of privacy and the sense of inclusion. So for someone like Ken Barlow, you know Philip and Lisa are significant, an important part of his life system. And if there's a crisis, in ambiguous circumstances, you'd feel in the exercise of your professional judgment that it's in his best interest to reach out. Fair enough?
Very fair.
But I mean, these are skills that we have to help people develop. It's not just developed by hearing a lecture, but by practice and applying them over time. And finally, I think this may happen more in other areas of medicine than mental health, but there too, sometimes, and I'm giving away a secret here, sometimes health professionals hide behind the law because they experience the family as a pain in the neck. So it's an excuse. I'd like to talk to you, but the law prevents me from doing it. Have you experienced that you're nodding? I'm sorry about that. You don't seem like a pain in the neck to me. So I want to close with a few suggestions, practical thoughts. One is that professional training has to include family-related skills. Back in the 70s, I was responsible for an inpatient psychiatry unit, and I recognized that we were really very unwelcoming to families. The Dylan song was playing in all of our minds, and those concepts that I was up here were in the background. And a lot of the staff was young, in their 20s, earlier 20s, and carried attitudes of, I'm on my own feet, independent, get off my back. I was of the august age of the early 30s. But being over 30, I was no longer trustworthy in those days. But I did a course, a program for our staff on dealing with families, and we did readings, and we brought family members in, so we did stuff, and I think we changed our attitudes. Second thing, training in hospitals particularly about compliance with the law has to emphasize what can be done rather than be driven by the fearful, don't do anything that might possibly rock the boat orientation that often happens. And I don't know if this is as true for nurses and nurse practitioners, but among physicians, if you're talking about a complex social, ethical issue, often the first thing that they say is, what does the law say? And just as you have to focus on the language, as with Ken, who said, I have bipolar, the first question to ask is, what's the right thing to do here? And then you ask, how do we do it in the context of whatever the laws are? And if it appears that the law says you can't do the right thing, then ask, well, how do we either disobey the law constructively, change the law, or find a way of making do? And that's a different spirit than health organizations often have when they're talking about how to operate within the social and legal system. And for families, so for those of us who are dealing with health professionals, if we're told, oh, I can't talk to you because of HIPAA, at the very least, and this happened all the time in my practice of psychiatry, at the very least, you can hear the information. So Ken Barlow's doctor can hear he's walking at 6 steps per second rather than 5 steps per second. And the person can say, thank you. So even if you're not giving information, you can receive it. And something I saw a lot in my years of practice, sometimes, frankly, we were just rude, treating people as if they shouldn't be talking with us. And at the very least, if there are circumstances where really one feels one can't talk, but we ought to be apologetic in a nice way, explain we can't do this, we'd like to, blah, blah, blah. But there are no circumstances in which health professionals cannot hear information. So if someone says to you, I can't deal with you because of HIPAA, in a polite way you can say, just shut up and listen, because listening is doable. And finally, just as a practical suggestion, when there's a large system, 6 brothers, 4 sisters, 2 parents, grandparents, a lot of friends, designate a lead communicator so that you've got an organized interaction with the health professionals. But the bottom line of all of this is that, and this event is really a very rich teaching example of what this is all about. That a person with a mental ailment needs to do work on his or herself in managing that ailment and recovering from it. But a big part of that process depends on the environment that person is part of. Ideally, with good luck, there's a wonderful family, but whatever there is, there's family, there's friends, and we need to find ways in which that caring community can join with the health professionals on behalf of the recovery process. It's doable. I can say from experience, it's both practical because you have allies. I'm talking now as a psychiatrist. You have allies. Everything's not on your shoulders. You're working together with others. And you have a team. You have a team of helpers. You have a distant early warning. This is actually very important with bipolar illness or recurrent psychosis of any kind, to have a sense of the early warning signals and having those brought to attention. So that's the large message that I think we've seen evinced here in a very moving and powerful way tonight. So thanks to all of you, and thanks to Danielle and Ken and Lisa and Philip and all the rest.